so I've been at MCW since 2001, and you know, in general, my focus has been on HIV treatment, HIV prevention, STD treatment, and kind of all along the way, I've had the opportunity to take care of transgender patients, and kind of began prescribing hormones in kind of a limited capacity within the HIV clinic, and then have expanded the number of patients that I will see when we open the new clinic in July.
Perfect. So I'm Jessica Francis, and I was at MCW for residency from 2007 to 2011. And then I left for a few years and went down to Texas. I was at Baylor for a fellowship in pediatric and adolescent oncology. So it was during that fellowship that I did a lot of work with kind of hormone management and hormone manipulation in a population down there at the Children's Hospital. So then when I came back to MCW in 2014, I had a partner who was primarily taking care of the LGBT population through our clinic, and she asked if I would take over her practice. So it seemed like a very natural fit. So I've been doing this at Froedtert since 2014.
I'm Joanna Woodbury. I've been with MCW since 2010. So I provide social work support and program oversight for our clinic that provides support for people living with HIV. As well as in the inclusion clinic. I'm not super wordy unless you ask me questions, so that might be all I have.
Great. So I forgot to mention, I'm also on the board of the center, so it's nice to be here, though I'm here a lot for other reasons. This is kind of more fun than most of the reading sessions. So we don't have to spend a lot of time on these cases, but I thought, I mean, people probably all have their own examples of why having healthcare providers that understand who each patient is an important thing, but I like to include them just in case. So the first case is a patient named Louise, who's a 59-year-old woman, and she developed fever and chills after having a surgery on her neck. I made these really short. Right? In the end, the source of the fever was actually her prostate gland, but none of the people taking care of her knew that she had a prostate gland. So that's one example of why this stuff matters. Another case is Jake, who was a 45-year-old man who came in with chest pain, and upon the rest of the workup, it turned out that there was cancer, that he had cancer, and it was actually metastatic breast cancer from residual breast tissue that he had. And no one had discussed with him breast cancer screening, even though he had two relatives who had breast cancer. And I started that because there actually isn't agreement on what to do with breast cancer screening, but certainly if you had someone that had two first-degree relatives with breast cancer, you would talk about it and decide whether you should do something about that. And finally, this is an interesting case. This is a 26-year-old man who went into the allergy clinic, and they were working him up to see if he had asthma or not or something else. So they do these things called pulmonary function tests or lung functioning tests. And so what they do is you go and you basically like inhale and exhale into this little thing that measures the volume of your lungs and all that stuff. And that's a good way to see, do you have asthma? Do you have some other what's called restrictive lung disease? Like if people get like asbestos, then their lungs don't expand very well, so they have restrictive lung disease, it's called. And when the results came back, they showed a restrictive lung pattern, which was not at all what they were even thinking about. They were trying to say like asthma or not asthma, and that doesn't look restrictive at all. And it turned out that this was a transgender guy who was wearing a chest binder to the pulmonary function lab, but nobody knew that. So it looks like something completely different on the test result. So anyway, these are good examples of like why we need to understand our patients better than we do. Okay. So this isn't a very fun topic, but I wanted to talk about like why do we care about these things? So there are a lot of health disparities that we see in all LGBT patients, but especially certain things in the trans community. And there are a lot of things that go into making up health disparities, right? So part of it is kind of bad things that happen within healthcare, so bias in healthcare. Some of the health disparities have to do with like how our society treats people. So a lot of people have to deal with minority stress in one manner or another, and that actually can make people sick in a lot of ways. We could talk about the kind of things like depression, anxiety, substance use are sometimes rooted in the way people are treated by the world the way it is today. So, of course we can't deal with all of those things in the healthcare system, but we can definitely deal with some of them. So what are some of the barriers that people talk about? Well, so having health insurance is one important aspect of kind of accessing care and getting things that people need. And there has been a long-standing problem that LGBT patients, and especially trans patients, have been less likely than other people to have health insurance. Of course, there is the fear of going in and having a bad experience in the healthcare system. And then there's like the individual relationship between a patient and their provider. And so there are issues worrying about like, well, what happens if I tell the provider something? How is that person going to treat me? Or like, who else is going to find out if I go to this visit? Who's going to read what's in my chart, or who's going to like be at the office and see why I'm there? So those are some issues that have been talked about for a long time. But you may be familiar with the results of this survey. So the 2015 US Transgender Survey conducted by the NCTE. And so this is actually a really successful 27,000 respondents. It's like excellent. And they had people from all 50 US states and territories, which I thought seemed like a lot of work, especially territories, right? So to do all that outreach, so great. So what they found in this survey was that 14% of the trans people who answered the survey were uninsured. In the general population in the US, it's about 11%, although that moves based on other things that are happening at the time. So one of the questions they asked about was, are people out to some, all, or none of their healthcare providers? So 40% of the people said that they were out, meaning they had disclosed kind of their gender identity, sex at birth, to all of their healthcare providers. And then 30% said that some of them knew, some of the healthcare providers knew and some did not. And then 30% said that none of their healthcare providers knew their gender identity, which is a problem, as we mentioned. So that's pretty impressive to me. And then of course they asked people about what kind of experiences they had with the healthcare system in general. And I mean, I was a little surprised only a third of people had some negative experience. I would have guessed it would have been higher. And so these add up to more than a third. So people could have had more than one of the negative experiences. So 25% said that their negative experience was having to teach their provider something about how to take care of them. 15% said that they were asked unnecessary questions during a visit. And then it gets worse, but luckily a smaller percentage. But so 6% of people said that they were verbally harassed during a healthcare experience. 5% said that their healthcare provider used harsh language toward them during their visit. 3% of people said that they had a healthcare provider refuse to provide them services. And that is not like gender-related care. Which some people just don't know, some providers don't know how to do that. This is like they refuse to take care of the patient. And then 2% of people said that their healthcare provider was physically rough or abusive with them during a healthcare visit, which is, like shocking, horrible things. So these are the kind of things that motivate us to want to do a lot better. So if you might guess that with those kinds of experiences, people would avoid healthcare. And so what this survey found was that 23% of the people who answered the survey said that they had purposely avoided going into healthcare settings because they were worried about being mistreated. So we do know some things about which types of healthcare disparities exist for transgender people. And I have them listed. It's kind of depressing to go through all of them. In some cases, some surveys that resulted in these data lumped trans people in with other LGBT people, so there's not great data. But for some of them, this is clear. And these are all things you might have guessed about. But you know, these are common things that that we see in the rest of the LGBT community also. But for a lot of these, there is specific data on the trans community. So these are the kind of things that we care about and we want to make better than they are now. There are other things that are not exactly related to healthcare, but there are things that we like to kind of screen for and try to help people with when we have the opportunity. So we should be thinking about these things, which are things like hate crimes and sexual assault and domestic violence, which go underreported in general for kind of obvious reasons. People don't want to deal with police necessarily and things like that. And then an emerging issue is aging. So what happens to people who are trans when they need to go into a facility, meaning like nursing home. So these are issues that haven't necessarily come up a lot before, so these kinds of facilities may not have a lot of experience with dealing with them, but they will as we all kind of get older, right? So a lot more people are out nowadays than in previous times, so this is going to be kind of an ongoing issue. So we're here to talk about, well, this is why we care. What have we been doing so far at Froedtert and MCW? So first I'm going to talk about what our whole system has done, meaning the whole Froedtert Health, which is the 5 hospitals and a bunch of outpatient clinics. So one of the first things that we did was to attain leader status from the Healthcare Quality Index, which is done by the HRC. And we started working on that before 2014. But that was the first year we obtained it. We were one of the first hospitals in this part of the state, or the eastern half of the state, to get this status. And we've been able to maintain that every year. So a lot of work went into that. So it has to do, there's a whole bunch of requirements which you can look up, but a lot of them have to do with ensuring that you have policies on non-discrimination for your employees, visitors, and of course patients. And it also has to do with education of your staff members in your hospital and clinics, along with a whole bunch of other things that go into getting that status. So there are other things besides just getting that status that we've been doing. So we have kind of ongoing education of our hospital and clinic staff through some national resources, like the Fenway in Boston has what they call the National LGBT Health Education Center. So they have online training that we utilize for our hospital staff. We started holding about 5 years ago our Transgender Health Symposium, which people from Forge have been helpful in obtaining either panelists or helping us locate speakers. And that's been a very popular event. That's something that we invite the entire campus to, so meaning students like our med students and pharmacy students, but residents and physicians and nursing staff and social workers and basic scientists. So everyone's invited to that, and it's been very popular. We also have training that's delivered by our people within our institution to our employees and staff. So something that's coming up is that although we're here to talk about our new clinic, we're interested in making sure that our whole system gets better and better for our LGBT patients. So we, meaning the clinic, the people who are involved in the clinic, who we'll talk about in a second in more detail, are going to start doing training for all of our primary care providers throughout our system on LGBT health. This is something that we're interested in doing, and people seem like they're receptive to, and so that should be starting in the next few months. Froedtert has something like between 40 and 50 of those outpatient clinics located starting now from Kenosha up through like West Bend or something like that. So we have a lot of work to do. We do have dedicated resources to improving our competency around taking care of LGBT patients in our diversity and inclusion office of Froedtert. And they've been very helpful all the way along in all of the kind of activities we're doing. And starting last year, we initiated a LGBT employee resource group, meaning it's not a support group. It's actually a group where people can get together. They usually do community outreach, things like that, but also have a chance to give feedback to us and our system about how the system is doing with regard to being an LGBT employee of the organization. Okay, so that's a lot of stuff. So now, this is the good part. Okay, so we opened in July the Inclusion Health Clinic after several years of planning. So let me tell you first what we do. We tried to offer what we think are the most useful services so that people can get a lot of, or almost everything that most people would need in one place. So we do, of course, general primary care. We do gender-affirming hormone therapy. We have OBGYN care. We do treatment of HIV and HIV PrEP. We have endocrinologists on our staff, and we have a practitioner that does psychotherapy and also prescribes psychiatric medication. And we're open to seeing, we're going to be looking at when we end up referring people outside of our clinic, meaning patients who need different services than this, we're going to see what the most common referrals are, see if we can incorporate that into our clinic in the future. But in the first year, this is what we're going to be doing. We accept basically any kind of insurance that lets a patient come to see us. So most things. Certain employers have plans that restrict, their employees to only go to a certain hospital system. So we can't help that, but we'll take any insurance that will let people come to see us. We will see any LGBTQ plus person who wants to come and see us. And we can start seeing people at our clinic at age 15. For people who are under age 15, there is a gender clinic at the Children's Hospital, which we also have some materials on, that we're pretty separated from. So that's a whole different world over there. We are not trained to take care of kids, so 15 is our age that we will start seeing people. We don't have a test to tell people are LGBT. We did, so you just have to call and say yeah. Honestly, we talked about this. Well, what happens if everybody just starts calling? Because there's only 7 of us, right? So we couldn't handle if everybody wanted to start coming to this clinic. But so far, we haven't had a lot of people who randomly call the clinic. That's why we actually wanted to keep a separate phone number, which we've done so far, which is hard on our front desk staff. It's a lot of calls. Instead of using the central phone number that the whole system uses, but we're doing all right. So what have we done to improve the experience? So some of these things we have full influence over, and some we don't. So if you've been to the doctor, you may have gotten one of these forms that you get in the mail ahead of time, and you fill it out and you bring it along. It seems primitive, right? It's a piece of paper, but anyway. So we did a few things. These are changes from the prior version of the form, which we had some input on, but not complete control over. So we added right away, I like to be called. And we added pronouns right in the second line. This part I'm not super happy with, but it got better from what it was before. So we are able to ask about gender identity and sex at birth, which is important. I didn't really like how that first line came, so this is going to be my revision for the next version, because I didn't think anyone would check that box. It says just transgender. So anyway, but the next version is going to be great. Actually, I hope that there is no next version, because paper doesn't seem like it's very useful. Okay, and then there was this section of the form which used to have, in all caps, it would say women only and men only, and I was just I don't think people need help figuring out which of those things apply to them. And so how about instead of dreaming up something, if we just take those words away and people will just tell us if they're having any of those problems, and then we'll just see what's going on. So, okay. What else? So what will happen after visit? So we want to make an environment where people would feel very at home. We had this up in June. This is as you go into the clinic. Someone made up this beautiful poster, and we left it up to almost July because we were so happy that it was there. Anyway, There are non-gendered restrooms on the way in, and of course behind the doors when you get back into the clinic. We have a lovely staff. We had a full day training with Ryan Salins, who's kind of the third from the right there, who's a national speaker or trainer on trans health issues. That was a very invigorating day that we all had. And then there's the providers at the clinic. We added one person since this has been made. This is kind of our first marketing materials. So I'll just pause here for a second. We have in our group Dr. Jacqueline Dinesen, who's a family practice provider. You met Jessica Francis already, and I'm there also. We have Dr. Sarvadio, who is an endocrinologist. Jeff Miller is a psychiatric NP, so he does both provide medication and do psychotherapy. And then Annie Mikados is a nurse practitioner who does primary care and hormone therapy. She's internal medicine trained. And since we made this, we added Dr. Raj Narayan, who's also from OBGYN department, who has a large trans practice and a long history of taking care of transgender individuals. And now I'm going to tell you a little better news about our electronic medical record capabilities. So this is a new module in Epic. Epic is one of the several electronic medical record vendors, but Epic has like a 50 to 60% market share, so they're kind of the biggest player, and they're located in Wisconsin. So we are able to give them feedback, although they're pretty slow. But anyway, I shouldn't have said that. Okay. So now we have the ability to capture better information in the medical record, which is what we want. We want to be able to have information that's in a place that's useful, so everyone knows where to look at it. So if someone else is going to be seeing this patient, in that day that I'm not there, they can like kind of understand who the patient is. So we have ability here to capture sexual orientation, and then we have gender identity, and here we actually were able to add things that weren't in the standard packet. So we added genderqueer, there's gender fluid, and like I don't want to answer your question, which is always a good thing to have. And then if someone wants to use any other identity, it's fine, and then a box will open up to put in whatever the person identifies as. And then we have sex at birth, pronouns. Sorry, it's getting smaller, but and then we can kind of keep track of what a person has done to date. So that they present as their gender identity, that they have a name that's different than their legal name, or they've already changed their legal name, they've changed their sex legally, or they've had surgery or are on medication. And then an important part of taking care of people is knowing what organs they have. So this has an organ inventory. So the first line is all the organs a person has at this time, and then organs that were present at birth, and then what has been changed since then. So these are important things to know, like what kind of screening does a person need? Things like prostate cancer, breast cancer, all the things that we pay attention to. We need to know like what each person has. So this will allow us to do that in a organized and much better way than we ever had the ability to do before. So this module was added, luckily, it came to be available to our system earlier this year, and as they usually do, the IT people were looking to pilot this in a clinic before they opened it up to like the, I don't know, hundreds of clinics that they have within our system. So we volunteered to pilot it, of course. So this was in place the first day we opened our clinic. And starting last week, this is now open to every practitioner and every clinic visit within Froedtert Health. So we're very excited about that. And does anyone have any questions so far? I keep talking. Yes.
I'm a current Froedtert patient, I guess, or somebody comes there, and just a couple. I have a lot, but I'll just hit you. Right now, so if you're already in the system, this can be updated, I take it, without these nice LGBT questions.
That became available like last week to everybody outside of our
because when I went in and saw the person I'm seeing routinely, the primary physician,
Yes, yeah.
she put right at the top of my medical record, male to female transgender person, which from a medical sense, may be quite bad, but it was also, we always fear that people are going to treat us differently if they know.
Yeah.
And so you are this constant tug. I tend towards, I said it's better to be there, but it just, and so far people have been just fine. But I think what you're doing is good, and I guess we can't hide in the hospital. Thoughts on that?
Yeah, this is an interesting issue. So that is a concern, right? Like, if what we want is for the right people to have the right information.
Yeah.
We don't want like kind of it to be used in an inappropriate way ever.
Mm-hmm.
So, and it's tough because if for example, for certain things that you come in for, there may need to be a diagnosis code listed, and sometimes that is transgender. And that's kind of visible depending on where someone is looking. What I'm excited about from this is that at the top of the chart, it'll have gender identity listed kind of prominently, and it won't say like transgender. It'll just say what the gender identity is, which I think the areas where this can go wrong is when it used to be just the legal name and then the legal gender, that someone would get called out of a waiting room with the wrong name, or be misgendered, and in those kind of public spaces. But I mean, I agree. This is not. There are kind of up and down sides to the way that we use the information.
And I'm currently going out to the Moreland Clinic, which is out there.
Yeah.
And for other reasons, and I guess I also made peace with saying there are people, I may be the first person you've seen is a little different out there. So I'm doing some education process. I chalked it up, okay, this is for the good of everybody, this is a good thing. But I'm going to come to your place.
Yeah.
That's great.
Well, and we'll, thank you. And we're going to be working with all of the clinics too, to try to make things improved everywhere. But you're right, there is no exact right answer to this issue, and we hope that it's mostly much better so that we can take care of people better. But there is the potential that the information might be seen by somebody. I mean, nobody can see the medical record who doesn't work there, right? But in a way that isn't necessarily appropriate all the time. But there's ways of remedying that too, meaning people get fired. So. Wow, this Facebook Live thing is really not fun. So, do you want to add anything? I'm going to stop talking. Will you please say something?
Here, we have let's field some more questions.
Oh, okay. All right.
All right. Andy, you talked about referrals for gender-affirming surgery. Do you have like a database of providers that basically good records of known capabilities that you can call on, or we can
I have a slide on that.
Oh, very good. Is that one?
No, I didn't.
Not
Maybe I
yet.
should. How about if I keep? I'm almost done, and then I'll stop talking.
No, okay.
But the answer is yeah, I do. We do.
So, I don't really know how to form this into a question, but it kind of leads off of Brenda's question and comments. Is that for some things within the Froedtert system, like I'm in the Froedtert system. Most of my care by most of my doctors, physicians, nurses, whatever, they know, but some other of the staff that don't know, like somebody who draws your blood, somebody who calls you out of the waiting room, whatever. And for medical reasons, I have to have an ICD-10 code. I mean, I know there's some ICD-10 codes that allow you to put transgender stuff down, but for some reason, they have to leave my gender or sex as one that was assigned at birth. How is there a way that you can get around that and still be able to bill for what they need to bill for?
Yeah. So there's several issues around that. So what we've been discussing is you essentially in a medical record need 4 different places for sex or gender, right? So sex at birth, you may not exactly, what you want to know is like organs present, and that's another way of kind of getting at that, and then surgeries. But okay, so sex at birth is useful. Legal sex is good because that needs to match your insurance card, right? Because what can happen is, for any person, if things don't match exactly, the insurance is like, oh, we don't know that person. It doesn't match our system, right? If your birthday is off by 1 number, they're like, we don't have that person. So if the gender is off, they can just say, oh, we're not paying for that. So legal is useful for that. And then what we also would like is be like a medical gender, not even the same as gender identity, right? Because let's just say that someone identifies as male, like today, but they haven't started testosterone. So the gender marker goes out to the lab. There are certain lab tests, a lot of lab tests, the normal values are based on a range that are kind of where 95% of males and females fit, and that's how normal values are developed. And the normal ranges are different for males and females for a number of labs. And a person's lab values tend to move into the range of their affirmed gender after 3 to 6 months on testosterone or estrogen. And that doesn't matter. It doesn't matter what their legal gender is, anything else. It would be great if we had a way to then say okay, this person's lab values should now reflect, whichever gender we've picked in the system based on kind of the medical transition at that time. Totally independent of all the other things. That doesn't really exist in any medical system, but that would be the right thing to do. And then on top of that is just how someone identifies. Right? So there are really 4 different places where markers would be useful. We're kind of getting to where there's 3. So things are getting there, but the world just doesn't kind of get there fast enough.
Yeah.
And by the world, he mostly means insurance.
Yes.
Right, insurance.
Yeah.
Right,
Yeah.
because my concern is more it's so fun to go in the system on my chart and be like, your gender has changed every time you've had a lab value drawn because it needs to be this for this one, this for this one. But somebody who's calling me out of a waiting room needs to see, will refer to me a certain way because, hey, guess what, the gender says this on here, even though they can visibly look at me and say, that doesn't look right. And I've had questions are you sure this is you?
Yeah.
Yes, I really need this lab value drawn,
Yeah.
and it needs to be, the insurance isn't gonna pay for it if it says male, but everybody else questions it, or they refer to me in the wrong way in the waiting room.
To me, this is one of the best things about this clinic is, for me being in an OBGYN clinic, if I have a trans man who comes to see me in the OBGYN clinic and they're very early in the process, okay, maybe that's slightly more comfortable, but as that process progresses, it becomes incredibly uncomfortable. And same thing for a trans woman starting the process. They do not want to come sit in the OBGYN waiting room. And we try to have our support staff, our front desk staff, and our MAs do a great job, but they see so many patients in a day and they get kind of locked into their routine. And it's not as easy for them to shift gears as much as they may want to try to be very inclusive. So I'm hopeful that we can at least eliminate some of the waiting room stress by having this clinic. And then hopefully the lab will be shortly to follow, because I know the lab is another very hard place to go. And I tell patients all the time, okay, just go to the lab and tell them your name and they'll know what I want. But I know it's not that simple once you get there, because again, people are trying to match something in a medical record to something that they see visually, and it's not always congruent. So we're making slow and steady progress in our health system, but again, insurance will be a whole, insurance companies will be a whole separate bear.
Yeah.
Did you have a question?
How do you handle legal versus preferred name? One issue is when I need to give legal name or something similar versus when I can use a preferred name.
So we would need a legal name to match like insurance records and everything else. So we need that. And then the preferred name now we can put in like right away. And what I was going to say is that starting only last week, there's a banner on the top of the medical record screen, and it has like 12 or 14 different things in it. And it used to be that the person's name was in larger font than everything else, right? Because then they like your medical record number. And the preferred name was also this tiny little thing. And now what's happened is the preferred name is the largest thing and the first thing that a person sees, like when they open the chart, which I think is going to be great. But the other thing we found out in this process is, so the Epic is what like we kind of live in, like we use it all day, and that's like your medical record. Epic interacts with more than 100 other electronic systems. The lab system, when you go to radiology, when you have an EKG done, like those are all separate software systems. And so that's why this stuff actually takes, so one of the reasons why it takes so long. Like there are so many interfaces, and how do those systems going to handle like the fact that we now have 3 different kind of places for sex or gender is almost like nightmarish. Because those systems are not maybe equipped to handle like what Epic can actually do. So, I mean, it's getting better, but there's a lot of reasons why it's complicated, which isn't fun.
Or like, or even a simple question. Say if I were to call to make an appointment and state my name, what name do I state?
So in order to look up your medical record, it's attached to the legal name that's listed. So we're not able at this time to search it based on preferred name. Now, for instance, in our clinic, if you called and said, this is my name, the second the scheduler started scheduling, that person would refer you by your preferred name because we would see that and immediately use that. But a general scheduler, all of us can only look up based on legal name.
So, I thought I would put in here like what to expect if you come to the clinic. So the stuff in the left column is what you might expect in general if you went to a new patient visit, or what you should expect. So, you know, your medical history, mental health history, your social history, sexual health, and your family history. Those are things that are usually in there, either on paper, and if you say like, no, I don't have any of that, then it's quick. I think the things on the right side are things that should be done, but are not done in most places, but will be done when you come to see us. So things like family planning and fertility concerns are very important in the population that we see. Prior hormone use of silicone injection, previous surgeries, as we mentioned, and organ inventory are things that we'll pay more attention to in our clinic. What else to expect? So these are things that, you know, we're accustomed to doing, but we want to just put out there that this is the way we practice. So we'll use your terminology for your body parts, right? People like to use a variety of different terms, and there's certainly no standard way, and there's no standard time that people change the way they may refer to their own body parts. And I was at the Gay and Lesbian Medical Association conference, and someone presented a study on this, and you know, something like 2/3 of people, of trans people, like kind of the medical term for things, and 1/3 like another term for things. And so the idea is like, just use whatever you want. That's fine. We can all understand each other. A physical exam can be something that's distressing for some people, and so we will only do them if you know why it's necessary and if you say it's okay to do it. Seems easy, right? But that doesn't happen all the time. I thought it was important to put this in here. It's like if in our clinic you may be asked to see a learner, we use that term generally because there's med students and residents and pharmacy students and things like that. So you may get asked to see one of them if you come to see us. And we think that it's important that we do that because we're at a medical school and a pharmacy school. And we want there to be more practitioners out in the world when they're done with their training who know what they're doing. So we want them to be with us and learn how to take care of LGBT patients. But if that makes you really uncomfortable, or even a little uncomfortable, if you don't want to do it, you don't have to do it. But you may get asked, and you'll always get asked. But that's part of our mission as an academic medical center, is to make the medical world better at doing this work.
And I will say, if you're like, no, I'm not into it, there's no uncomfortable feeling about it at all. So, for instance, I have said no to a learner every single time I go to the doctor, because I see you in the hallway and I have no interest in you being up in my business. And, I have had clinics who are like that, are kind of stinky about saying no, and some clinics that aren't. And in our clinic, it's like, cool, that's fine. There's no feeling like you did something wrong.
And you should know that, this is maybe getting too much detail. The learners that we have at this point in time this is not a required rotation. So the people who are with us are people who really care and they want to learn and be better at this stuff. So it's a really friendly audience. If there's ever a day where it's a required rotation, there may be people who are disinterested or whatever. It may be a little bit different feeling, but right now, it's great. It's people who really want to be there.
Yes, exactly.
And when you make an appointment for our clinic, you will get a letter in the mail that has the clinic medical director's email and phone number in it. Because, I didn't spend the last 5 years trying to get this clinic open for myself. I really wanted to be an asset for the community. And we want to know, is there something we should be doing differently? How can we do things to best meet everyone's needs? So we want to know about that. And so please let us know if there's any suggestions, feedback, good, bad, everything is fine. So this is a question I thought I would just put right out there. Do I need a letter? Okay. So we all talked about this in our clinic meetings, and we came up with this. It's a paragraph that's going to go on the website when the website gets improved. But we say, in most cases, we begin gender-affirming hormone therapy using the informed consent model, which is that if you talk to somebody and they understand what's going on, you just go ahead. But we encourage people to have an ongoing relationship with a mental health provider that they like and have a good relationship with, so that that person can be there to assist them through all of the things that happen when someone starts hormone therapy. There are emotional, physical, and social changes that happen, and we think it's a really good idea to have someone who's good at talking to people who are going through those changes to help them along the way. And only in certain circumstances may we request a letter before we would start hormone therapy. So we're not really big on that. We're big on having a good relationship in place. So that is our kind of stance on that. Okay, so what else? So there are 7 of us, and we're doing what we do in the clinic. But these are other services that are available at Froedtert, and we can make specific referrals or provide the names of the exact people for each of these services. So there are people who do voice therapy, laser hair removal, and makeup training in the kind of aesthetic center. There are people who do facial fillers. There are other people who do facial and neck surgeries. There are breast surgeons who have experience with reduction and augmentation. We have people who do hysterectomy and orchiectomy, all in our system. So, and if you are, we will refer patients from our clinic to any of these places and talk through who's available in each of the other clinics.
So I assume that all the resources that you would refer us to are LGBT friendly and familiar with the reason we're doing this, and they're not going to say, well, why do you want to do this? Right? Yet they won't challenge us.
No. So the way that I've been around a while, so I know people, but what we did last year was I emailed everybody in the Department of Plastic Surgery. And I mean, I knew most of them, but you know, new people come with it. Emailed them, and then like ENT and dermatology and on, OBGYN and urology. And I said, like, this is happening, and we want to know, like, do you have previous experience? Are you interested in seeing more patients now? And would you like to be included in our referral base that we send people to? And so, I mean, the answers are usually like, well, people don't answer you. Because, like, doctors are horrible at answering email. Just look at my emails. Or, I mean, a lot of people say, absolutely, I've been doing this, like, and I already knew, like, that we, you know, have been sending people to certain of these specialties. Or the new people say, yeah, I've done a lot of this. I'd be glad to do it now, here too, right? So the people are like vetted already. So we're not just guessing. We know who these people are, and we've talked to them already, and they're already seeing trans patients in their practice.
Yeah, sort of related. What about specialists that don't deal with this stuff, but you know, regular specialists like a cardiologist or you know something like that? Do you have a list of people that you talk to, or is it depend on what the patient needs?
I was just going to address that. So I don't think we have a full list of all the specialists that we need at this point. So what I typically will do is if it's not something that's very time intensive, I'll just send a message to somebody in that department that I know vaguely or well, and just say, hey, I have this patient who needs these services, this is a trans patient, are you willing to provide a good patient experience here, or do you know someone who will within your division? And they'll write back and say, sure, here are some names for you, all of us, you know, blah, blah, blah. Now, there are some instances where we're trying to make a referral that needs to happen pretty fast medically. And in that instance, since most of our referrals go through the computer system, if I'm placing a referral right there during your clinic encounter and I don't know somebody in that department, what I'll typically do is I recently had to do this for pulmonology. I don't know anybody in pulmonology. So I made the referral, and it needed to be an urgent referral for very poorly controlled asthma. So I put in you say what you did the referral for, and if you have a specific provider, and then you can put comments. And I specifically put in the comments. And again, this is tough for you guys because maybe you don't want everybody to know your status, or you know, you have an established relationship with this provider. But in that instance, I do specifically put, this is a male to female, female to male, transgender patient. Please help this patient get to someone who is going to provide a good patient experience. So I hope over time we do have a very comprehensive list of subspecialists, but sometimes these things come up when we don't foresee it, because as a gynecologist, I incredibly rarely refer to pulmonology, so we just sometimes don't make those connections. But over time, as we pool our resources, I think we'll be in a much better position to do that.
Just one thing I'm worried about. Is there any recourse should I happen to go to the doctor, but the doctor refuses to treat me for, quote, religious reasons?
So,
is there any recourse?
can we come back to that? I mean, I don't want to. No, I didn't. Well, things are happening. Well, I can just state some. These are just things that are happening. So right now there is the president's administration is forming an office within the DHHS of what is the right way to say this? Yeah, I know it's not a word. Yeah, so an office of religious freedom.
Yes.
So there's concern over what that will mean, but it's not formed yet. It's not clear what's going to happen. I'm also on the board of the Gay and Lesbian Medical Association, which is located in Washington, D.C., and it's paying very close attention to what that means. So I don't think there's any one answer to your question. If you're not treated well, there's probably some kind of recourse, but it's hard to say without a specific instance of what that could be.
Andy, could you talk about what the Froedtert system is and what Froedtert requires of its employees, and what, is there a complaint system? Because we can't ask for everybody in the country, but we could ask for Froedtert's system for that.
Yeah, so my response to that really good question would be one, to point back to all of the certification that Froedtert continues to go through in order to maintain the status that Dr. Petroll talked about. When we have somebody who has a negative experience in our clinic,
Not our clinic.
no, sorry,
Some clinic.
in some clinic, I'm often made aware of it because I have such a close working relationship with so many patients. And we have a ferocious process of supporting a patient through that experience. So in addition to having an advocate within our clinic, Froedtert has an entire office called the Patient Experience Office that supports people individually, that will walk them through the whole process of making a formal complaint. I frequently have made that formal complaint in partnership with a patient. It doesn't happen that often, thankfully, but I've gone through it with a couple of people. And that starts from the top down, which they investigate the whole thing. They interview the provider or the individual on staff who provided the negative experience. And I mean, it can lead to termination depending on the experience. So it's it requires some patience, but it really is an empowering process to go through. And every time I've done it in the last 8 years, I can remember each of them, so you know it's not that many. But the patient comes out of it feeling affirmed and a resolution that's agreeable, and it's been a productive process that we take very seriously as a larger organization.
I would just add in general, so, I feel like I'm part of this community here, right? And I actually, when I think back, even just 10 years, not to mention 2001, I had no idea that it would be, that this workplace would be so wonderful and supportive of me in general, and this work that we're doing now. 15 years ago, things were a little different in general, but I feel really lucky to have full support. Through this work, I've gotten to know the president of MCW and the CEO of Froedtert Health. And these are people that, most of the time you don't meet unless you're doing something like that, right? Because there's 1,500 physicians and on, right? 20,000 people that work at the hospital. And I can stand in front of you and say these people are fully supportive of this work and us. And that makes me feel good about the whole thing. I always thought we would have to do this kind of subversively and sneak in good patient care, but no, they're yeah, let's do this. This is great. What do you need to do this? I mean, we asked for a new building, but we didn't get that. We didn't get everything you want, but in general, what I'm trying to say is that the system from the top is fully supportive of us, and that feels really good.
Since these services are, it sounds like, through Froedtert,
Yeah.
if your insurance covers general primary care and OBGYN care, do these services tend to be covered by insurance or no?
So most services that, if your insurance allows you to come to one whole system for primary care, it usually allows you to go to that system for any care you would need. Is that?
But I think what she's asking is the lists of things that you have on, other resources. They are dependent on what the carrier agrees to. So for instance, right, Medicaid says I'll do this, but I won't do that, and we maneuver through that in as many sneaky ways as we can. But there can be barriers, Facebook Live, that are in place because of the insurance companies.
I have a personal experience. I applied to get an orchiectomy and everything was peachy keen. I saw the doctor was good. I liked him. And he said, my nurse will take care of it all. Sent it in. I came back a nice letter from United Health saying, it wasn't we won't do it, but haven't done all this proper preparation. You need to have this and this and this. which I need to do, of course. But I mean, it's not like they do it. The insurance companies, as most of them, will try to wiggle out of things where they can get away with it. And fortunately now with Medicare doing SRS and things like that, I think it's becoming more acceptable, but it's not a walk in the park still. I mean, you need to do your groundwork and be prepared.
And right, and a lot of those things, you know, there's the reason that, you know, social workers' jobs are very challenging in general is there's thousands of different healthcare plans, right? Even though there's like United and Aetna and Cigna or whoever they are, right? Within those companies, they offer hundreds of different plans to different employers, and they can have different language and different exclusions. So that makes it all really difficult. Of course, more and more employers are making their insurance companies sell them plans that are including more and more of these things, but they're all still different. There's no kind of standard agreement on what should be included. That's how you reach us. We selected the year of the opening of our clinic as our phone number. Luckily, it wasn't taken. And so there are cards at the back tables if you would like to take